Maintenance therapy in this following second-line treatment has also been studied. The Continuum study, which was published last year in Lancet Hematology, showed the efficacy of using lenalidomide in this setting. In this trial, patients who had at least a partial remission after second or later line of therapy were started on lenalidomide and continued until progression. There was a significant increase in the progression-free survival from about 9 months without maintenance therapy to more than 30 months with lenalidomide. There was, however, no change in the overall survival. The authors and I speculate that this is probably due to the availability of other treatment options. And I think that does lead me to not automatically adopt this as a treatment option. Perhaps for the right patient, the patient maybe with more aggressive disease, or the patient whose response to first line of therapy was inadequate, or whose first line or second line therapy was abridged for other reasons, would then be a good candidate for lenalidomide. But I think it's also a reasonable option to monitor those patients closely and start drugs like ibrutinib or idelalisib should that patient relapse. Similarly, anti-CD20 antibodies have been studied as maintenance therapies after second-line therapy. Ofatumumab was studied in this manner and is approved by the FDA to be used as maintenance therapy. In that regimen, patients will receive ofatumumab for up to 2 years. The Prolonged study, which is what led to ofatumumab's approval as maintenance, did show a prolongation in PFS as well. But I think in my practice, I also have not been adopting this for most patients. Perhaps the thing that leads me to this decision is the knowledge that in other head-to-head studies, the kinase inhibitors have shown superiority to the single-agent monoclonal antibodies. But I suppose in following second-line treatment, if a patient has already had ibrutinib, or we know ahead of time won't have easy access to the oral inhibitors, maintenance therapy with ofatumumab is an option too. The duration of maintenance therapy, in my mind, should be guided by the trials that studied it. For ofatumumab, the duration would be 2 years. For lenalidomide, the duration could potentially be several years, or as long as the patient does not progress. Certainly there are considerations that we want to balance the risks of these agents with controlling disease, especially if a patient has other treatment options available to them. These agents do have risks of immune compromise, of viral reactivation that are, and other complications that are maybe not dose limiting, but not trivial either. And so certainly patients should be monitored for infections or those complications. With maintenance therapy, I usually do not expect, or with the maintenance options, I usually do not expect eradication of minimal residual disease, so I do not necessarily monitor these patients by flow cytometry or by marrow biopsy. But I suppose if there is a decision to be made about whether or not to continue, those tests can help guide patients one way or another. In the third line and beyond, fortunately, there are also usually options for patients. Certainly, the treatment options will be driven by what treatments they've had before. Patients who have already had chemoimmunotherapy and ibrutinib will likely be deciding between idelalisib, should a patient have had intolerance to ibrutinib but not progress on it, or venetoclax for patients who have progressed on ibrutinib or have deletion 17p. For patients who have not yet had ibrutinib, I would consider that the standard third-line option. With the current treatment options, there certainly are patients that can be treated in an entirely chemotherapy-free manner or chemotherapy-sparing manner. using regimens like ibrutinib, venetoclax, idelalisib, monoclonal antibodies. Our group at UCSD often uses high doses of methylprednisolone. And so I think for patients that are driven to avoid the potential toxicities of alkylating agents and purine analogs, there are fortunately a number of options. I do not think patients who have not had chemotherapy in the first-line setting and are now requiring treatment should feel compelled that they must receive chemotherapy. I think that decision really should be made based on their fitness and based on their treatment priorities at that time.